name is Senyo. I'm a surgical resident from Kolebu Teaching Hospital in Accra. My official hospital where I work is in Techiman. And what I'm presenting today was actually done whilst I was still working in Techiman before I moved to the teaching hospital. Ghana is in West Africa. There is no Ebola in Ghana. We are doing well so far. The population is about 25 million. We have, in all, we have 10 regions, and there are 257 hospitals in all. Of these, 4 of them are teaching hospitals and 10 are the regional hospitals. So the regional hospitals with the official teaching hospitals are the main referral centers. All the regional hospitals are also teaching hospitals, and that is quite good. So today I would like to talk briefly about some of the challenges we face when we go to the district to work as young doctors, and how we can help children with uncomplicated intussusception. Basically, intussusception is just a telescoping of a segment of the bowel into the adjoining segment. That obviously leads to intestinal obstruction. And as surgeons, we know once there is an obstruction, we have to relieve it. Otherwise, the complications follow. Generally, there are 2 ways you could manage this. There are the non-operative and then the operative approach. The operative, unfortunately, in sub-Saharan Africa, if you have a child with intussusception in the district, you have but one option, and that is to open up and reduce the intussusception, or if the bowel is gangrenous, then you have to do a resection and anastomosis. The non-operative methods are being used. This is currently the standard of care for these children. So you get the children with intussusception, they present, you resuscitate, take them in, reduce it without having to open the abdomen. And that is the standard care, and that is what we are hoping to do. But this is interesting because this kind of reduction in Ghana only started in 2008. And that started in one of the teaching hospitals. Then later, the hospital where I work now is doing the hydrostatic reduction in 2011. They did a few studies on that, and they've been published in the literature. So what happens? The problems in the district. One, most of the articles you find on intussusception, the reduction, are done by pediatric surgeons. They are done by qualified radiologists in the presence of qualified anesthetists. So obviously, these are lacking when you are working in a district hospital in Ghana. We usually have just general medical officers who are practicing, who have to do everything. And you need some other equipment. At the time we started this work, we had only one ultrasound in the hospital where I was. And that ultrasound was dedicated to the maternity because we're concerned about mothers. So it was dedicated solely for the maternity. The compounding problem in the district is what the patient factors, and these cannot be ignored. The population is around, the population served by the hospital is about 500,000, the whole region. And it's a huge region, so people have problem traveling to the hospital. That is one. The second one is that most of these children would probably have a fever of some sort in the beginning, and they would see what we call the physician assistants who are further in the rural areas. Usually the first diagnosis is malaria in such children. So they would have received some treatment for a wrong indication. So that would take them about a day or 2 before they realize that no, the child is not getting better. Then they have to set off and then come to the hospital. They usually come late also because we also have a problem with our local, we have people we call the traditional healers. So they use herbs to treat and all that, and then it's only when it gets worse that they tell the people to go to the hospital. So these factors greatly affect what happens to the children when they present to us in the hospital. The challenge then was to find a safe and a cost-effective way of managing the uncomplicated intussusceptions. For the ones that are complicated, you have no choice. You need to open and reduce, especially. So we set out to do a bit of literature review. We also went back into the data that was available in the hospital to find out what was happening to these children when they came. And we did a retrospective review of the consecutive cases over an 8-year period. But for the purpose of today's presentation, I'll present 19 cases These were over a 1-year period. It overlapped with the time that we started the pneumatic reductions as well. And this part is not the whole data of the paper that we presented. It's just part of it, just to give you an idea of what we are doing. We had 19 cases reviewed. 15 of them were already complicated, so they had surgery when they came. 4 qualified as uncomplicated cases, and they had a pneumatic reduction. Now, we had a very strict selection criteria for the patients that would not have laparotomy. So for you to determine that this child has an uncomplicated case, you should have an onset of less than 24 hours from the onset of the symptoms. The child should not have a fever. There should be no clinical evidence of peritonitis. So you do this to also make it becomes more effective to have a selection criteria. So obviously, if you don't pass any of this, you don't qualify for the pneumatic reduction in the district. The problem with which we had in the district was to monitor whether our procedure caused an effective reduction of the adjoining lumen. And this was difficult, so we came up with this NG tube theory. I'll explain it in the next slide. So what did we do? We went through literature and saw that most people used air to attain the reduction. So pneumatic reduction in itself is not new. We didn't invent it. It's been done all over the world, but there are specific equipment that you need to do it. It is safe, it is very good, and if you do this, the mortality for children is less than 1%. Unfortunately, in our setting, the mortality for intussusception is between 64 and 65%. So that is unacceptably high, it's too high, even for uncomplicated cases, because they tend up to have laparotomy and the anesthesia, the surgery, and all that affect the children. So we came up with this idea of having a way to introduce air into the bowel and allow it to cause the reduction. The principles have been there, the application was difficult. So a bit about what happens. Basically, we had problems with there are two sphincters we need to overcome when we are doing these reductions. The first one is the ileocecal valve, and the second one is the pylorus, because we were using the NG tube, which was passed for the patient, to monitor whether there was an effective reduction or not. And it's a simple process, but then you realize that at the time of intussusception, most intussusceptions are ileocecal. And at the time that the bowel invaginates into the cecum and probably into the colon, there is the ileocecal valve becomes incompetent for a while, even after reduction. It takes some time for the bowel to regain the function. So if you achieve an effective reduction, the air you pump should probably be able to go through the bowel and then probably come up. With the pylorus, the theory that we used was that if you are doing an endoscopy and you need to open the pylorus, you keep your scope there for a while, you just insufflate it a bit, it reacts and then it opens. Most of the time, these children have obstruction and much of the bowel content is already coming through the NG tube, so the air just follows the same pathway. So at the end of the day, what you need to see in the patient to know that you have had a reduction is the appearance of bubbles in the NG tube, because we normally connect it to a bag of saline in a kidney dish. So we have a catheter, a normal Foley catheter, French. This is the first one we did. So these are pictures from the first procedure that we did in the hospital. So this is a normal Foley catheter, 24 gauge. This is also something that is readily available in the hospital. It's the aneroid gauge of a normal sphygmomanometer. So the BP apparatus, but you take off the sphig. You just take it off, and that helps you to pump the air. Connect the two, and then this is passed into the child's rectum, and then it's inflated with about 30 to 40 mils of air. This value is not arbitrary. This is what is in the literature. So we just took it. So we connected the bulb and the gauge. Then, to avoid leakage, we usually strap the buttocks of the child together with just a piece of plaster for the time of the procedure. And air is insufflated into the rectum using the aneroid gauge to a maximum of 120 millimeters of mercury. This is also what is in the literature. So these parts are not new. The parts that are new are the NG tube and then this kind of assembly. What happens after that? You just wait. Okay? You wait, the air finds its way, goes gradually, and then gets to where the obstruction is. There are a few cautions which I'll address later. All things being equal, the air should be able to push the bowel back and then you restore continuity. And that is seen, you wait for about 30 minutes and you should begin to see bubbles. You are allowed to do a maximum of 3 attempts. You should insufflate the air just 3 times, and each session is 3 minutes. And that is also well documented in literature. These are all from the literature review. Okay, so this is a newer version of what we did. With time, we modified the device a little bit. We got this portable aneroid gauge, which is quite good. This is where you insufflate the air. We have a nice connector that will fit nicely into any size catheter that you choose. And basically, this is your setup. All these are available in a normal hospital. You should find a normal catheter. You should find a BP cuff that is used to check the BPs of patients. The connectors may be a problem, but you can easily come up with something that you can work with. And the results are good. Our age distribution and other findings were as in the literature. Now, these tables are just to give you an idea of what happens. Of the 19 patients that presented that year, this is the percentage that came on or after the 3rd day. So these are 12 of the 19 patients came either they came either on or after the 3rd day of presentation. So those who could qualify for pneumatic reduction fall in this region. There was one case that came 2 days, but we're not sure of the history because the mother was not too coherent. Later, the father came and said it was 1 day, so he was included. He had a good reduction. So you realize that from this point on, these patients automatically do not qualify for a pneumatic reduction. This is already complicated, even if they don't have a fever. Bowel that has been ischemic for 3 days is most likely non-viable. So you realize that from the patient factor side, we lose most of our ability to not to do laparotomy for such patients. And the factors are as I listed earlier. This slide was an interesting one. When we began to do the retrospective review, we realized that the surgeons who had worked in the hospital before, they documented that the extent of the intussusception. So they would either write that the intussusception was ileocolic or ileocecal. We thought it meant the same thing because everything is cecum. Everything is colon, large bowel, basically. But then in our analysis, we found something interesting. And this is just to tell you what happens when you open up. Most of the times you are likely to resect. Now, this slide says yes, and then this one says, this says yes, and this says no. So if you look at the children that did not need resection at the time of laparotomy, you realize that the blue, I think it's dead. The blue bar is higher, and the red one is lower. But for the patients that had resection, for those that the surgeons had documented that the intussusception was ileocolic, they had a higher resection rate. And this has now formed a reason for us to do further studies, whether the extent of invagination of the bowel into the colon determined the probability of resection or not. This we didn't know before. But probably the surgeons had helped us to try and answer that question now, whether if you open up, the extent of invagination would also guide whether you would do a resection or you not do a resection. So this was quite helpful, and I thought I could just show it for you. The demographics we have are comparable. We realized there's I think I didn't speak about those who had the reduction. Okay. For the 4 children that had the reduction, 1 of them failed. And that child later went on to have a laparotomy. We realized that there was pneumoperitoneum after the first insufflation. So that's a complication you should be aware of, that you can have air leaking if the bowel is not viable. And that is also why most people prefer to use air rather than barium or other medium, because there's the risk that if there is a perforation, your contents will leak into the abdomen when you open up. Mortality remains high for most of our patients who have the operative intervention, mainly because of the late presentation. As at then, we had a small sample size, so it wasn't a comparative study. It was a study that is ongoing. It is actually ongoing to the end of next year, and it's being expanded to other hospitals, so we can determine the efficacy of the device that I just showed. There are commercial devices available for this if you can afford, but we are trying to see if this could be applied in regions where there are no or very little resources. So in conclusion, for our children who have uncomplicated intussusception, which if you come to a district setting, you are likely to see, we shouldn't deny them the benefit of having a pneumatic reduction simply because the things are not there. We can assemble it. The improvised device can be used to achieve the reduction if you select your patients well. It is cheap, it's readily available, it's easy to assemble, and you can train any doctor to use it. The learning curve is rather, after 2 or 3 procedures, the doctor should be able to do it. Thank you very much.